Hi, everybody. This is Anna Vick. I'm here with Push for Empowered Pregnancy. I'm the co-director of awareness for our organization. I'm so happy to be here with a very special guest tonight. I'm first going to let Sam introduce herself, and then we'll go with Dr. Tracy. And the topic for tonight is actually really pertinent to this week because we will be discussing some pretty heavy topics with more maternal morbidity and mortality, and we do have a takeover later in the week with an organization that we're so excited to highlight. So we'll talk about that later, but we want to make sure to give you some useful tools to advocate, always pairing, really important information for you to know with what you can actually do to reduce risk. So let's go with Sam.
Thank you, Anna. And thank you so much, Dr. Tracy, for being here with us tonight.
My pleasure.
So excited to learn more about what you're doing and, just tap all of your wisdom to help families advocate for themselves in pregnancy. As most of you watching probably know, Push, and I know Tracy and Anna know, Push is a new nonprofit. We just launched less than a year ago, actually, and we are dedicated solely to the raising awareness and ending preventable stillbirth. This is a topic that we don't talk about enough in the United States, that the majority of families that it's happening to have no idea that it's even a possibility for them until it's already too late. And most of us on our team are families who have lost a child to stillbirth, and we feel very strongly that even if we can't prevent every stillbirth, which we know we won't unfortunately ever be able to, we feel that every family deserves to know that they and their providers did everything in their power to give their baby the best possible chance. So that's what we're here to talk about tonight. And the thing, as Anna was mentioning, is that stillbirth, maternal morbidity, infant mortality, all of these things are very, very closely connected. And the issue that's at the root of many of these problems, and especially when it comes to the disparities and outcomes amongst different races and different backgrounds, is about advocating and about parents not being heard within the medical system. So this is something that Tracy has a lot of experience with, and she's going to share with us our story and everything she's learned and how she has transformed that into a new, really innovative type of medical care through her brand new practice, which just launched in December, called Blue Moon Perinatal. So Tracy, I'll let you take it away. So let's start with your background. Introduce yourself to everybody.
Thank you. So I'm so honored to be here with you guys tonight. This is a topic near and dear to my heart. I think that what you guys do, first of all, that's so important is I think that as women who are going to be pregnant, as women who are giving birth, we need to start being louder. And I just don't mean like verbally here in my house, but I mean louder. And we've been taught, we've grown up to be good girls and to be good moms and good wives and good everything, good friends. But being good doesn't necessarily mean being quiet. And one of the biggest things that I've sort of come to learn on my journey is I've always loved what I do. I do high risk OB. I trained in some of the most intense, incredible settings, cared for some of the most underserved, underpowered patients. But one of the things that always sort of came through for me was that, in sharing with my patients, I always felt that I advocated for them. But our system has changed radically and dramatically through no fault of our doctors and our care providers. Our medical system has become a system that has really disempowered patients. And yes, the medical system as a whole is critically important to me, but most importantly to me really is my field, is my parents, my families, my babies, what I do. And to be disempowered as a woman trying to conceive all the way through being postpartum or being preconceptual after a bad outcome is the worst time to become disempowered. And so, one of the things that's really become very important to me, both in starting my business, in having this talk tonight, in partnering with Push, is to try to make sure that we don't think that by advocating for ourselves and our pregnancy or our children, that we are not being good girls. And it's taken me I have to be honest, it's taken me till my midlife to start turning into a really loud woman. I've always been loud vocally, but not really in the same way that I kind of mean it. If we don't learn how to advocate for ourselves and our pregnancies in a good girl way, in the right way, you can get lost way too easily. And when you've got a high risk condition, or you are a pregnancy after loss parent, it's a really bad place to be disempowered and lose your voice. And advocacy does not mean being annoying. Advocacy does not mean being neurotic. Advocacy does not mean being anxious. And advocacy absolutely does not mean starting your sentences with, I'm sorry, but. And these are all things that, as I've grown my business and as I've really started to examine the system, have become really important. And there's some of the first points that I want to make. And so how did I get here? So my journey, so I followed the good girl route. I trained at Mount Sinai in the city for residency. I worked at Mount Sinai in Elmhurst, saw some crazy stuff, took care of some crazy things. And did my high-risk fellowship at Columbia in the city. And I came out here and I worked at one of our community hospitals for about 16 years. And
for anyone watching, to be clear, Dr. Shevell is a maternal fetal medicine specialist. So
thank you very much, Sam.
An
Thank you.
OBGYN
Yes.
that handles, the most complex cases.
Yeah, so it's high risk pregnancy, high risk OBGYN, and it's called a lot of different things: maternal fetal medicine, high risk OB, a perinatalogist, which often get confused with a neonatologist, which is the baby. So yeah, thank you for sharing that. And when I practiced, for the last 16 years, things gradually started to change. I was very lucky. I worked for a hospital, which meant that as a salaried employee of a hospital, I didn't have to see 40 patients a day. I got to spend an hour with someone whose baby was just diagnosed with an abnormality or without a fetal heartbeat. But as the years started to progress, the patients that came to see me were less and less aware of what was going on. Why were they here? What was the test that I just had done? Why are you doing this? Why are you telling me this? Can you tell my doctor what follow-up I need? And so even the time I was giving them started to not feel like enough. I literally had to tell patients how to get to their consult with the genetics counselor that I told them that they needed, because they couldn't get through on the phone, or they couldn't get through to their doctor's office to set up their follow-up testing that we had talked about. And so often I literally would take the patient, by the hand to my receptionist in the front and be like, here are the 18 appointments you have to make her, and please don't let her leave until she's done. And because that receptionist cared, she did it. But for most patients, that started to become incredibly challenging. And so I was the doctor who always gave out her phone number and, followed up with patients and called to offices, and patients would look at me like I was on crack. Like, they're like, why are you doing all this for me? Why are you, oh my God, you made a phone call to the cardiologist and you got me an appointment for next week. And they were shocked because our medical system can't do this anymore. And that was not okay with me. And so sort of my journey to sort of where I am today, really was that I became really, I couldn't really take it anymore when maternal mental health and wellness started to really come into the spotlight as a factor that needed to be addressed. And we just didn't have the machine to address it. And maternal mental health and wellness feeds into every single issue that we'll talk about in high risk, that we'll talk about with PAL, family pregnancy after loss families. And what I saw happening was not just my patients having a spotlight shown on something that they couldn't have addressed, but I realized as a high-risk doctor that when you experience chronic anxiety, chronic stress, chronic depression, and there's nothing to address your needs, your axis of your hormones is such that you can be affecting the baby that's growing inside of you. And that can affect our next generation. And so that wasn't okay anymore. And so I sought to get funding for a maternal mental health and wellness center. I decided I was going to bite the bullet and be a business person. And when that didn't pan out for financial reasons, I decided to do it on my own. And so Blue Moon Perinatal was born. It's my third baby. And and basically what I'm trying to do is women have amazing doctors. They have the bricks and mortars in places. They've got wonderful labor floor nurses, but they don't have the navigational skills to advocate for themselves in the system. And so sometimes even if they'll want to ask for an extra ultrasound or extra testing, anything outside of the norm is overwhelming to care providers right now. And so that was one of the reasons I was so psyched to talk about advocacy tonight, because if you don't advocate for yourself in this system, you're going to get lost. It's broken. We're just broken.
Yeah, absolutely. So tell us more. And just for everybody watching, feel free to throw comments in the chat. We are monitoring the comments on the Facebook, and we will do our best to answer your questions. So Tracy, tell us more about like what you've seen when you were in MFM. What are some of the situations that you've seen patients trying to navigate? I mean, you mentioned having patients that are not even be able to get through to get an appointment for a follow-up specialist, that kind of thing. Like where are people falling through the cracks?
So, oh my God, where aren't they falling through the cracks? So I'll give you I think that there are two like wonderful examples of patients that I have sort of made my first clients and what struggles they met with. They're not uncommon. They're happening right here. So I'm just going to give you two examples. So one of the first moms that I worked with was, I got a phone call from a friend, frantic. Oh my God, my friend just moved here to the city, from the city. She moved out to the local suburbs. She's going to deliver locally at my local hospital. And she's 23 weeks and she has like a 1.5-year-old and she was just put on bed rest and she's high risk and she's freaking out and she's on Google. Will you please talk to her? And of course I said, let's go. So she tells me her history. To give you just a little, I don't want to get too much into the background because this is a little upsetting to me. There was a questionable judgment call made on her management. That's okay. We can still work within the confines there. So we had a discussion. She was diagnosed at her routine level 2 anatomy scan as having a short cervix. And just for everybody watching, that would mean that she's potentially at an increased risk of preterm birth and all that entails. And she was very early. And so she went for her ultrasound at 20 weeks. Dr. X in the practice sees her at 22 weeks and says, oh, look, your cervical length was short. So let me just point out step 1. There was no communication from doctor to doctor. There was no communication that something was urgent or semi-urgent. Dr. X then said, okay, we need to put a stitch in your cervix. And I just want to make a point here. There are options. There are other options. And at that point, just for everybody listening, at that point, when somebody tells you something's risky and going on, that's a flag that you should advocate and ask for a consultation with a high-risk OBGYN to discuss your options. Some generalists, some general OBGYNs can speak to those risks. And if they can, that's amazing. But they should confirm that with you. They should say, this is what a high-risk OB will tell you are your options. So
this patient was not high risk before they identified the short cervix. And when they identified the short cervix at 20 weeks, no one even told her until her 22-week checkup 2 weeks later when she's at term of going to that.
Correct. And to be honest, it is controversial as to whether or not that short cervix put her in a high-risk category or not. But Dr. X decided it was, and he said, you need a stitch. Let's schedule it. Scheduled the stitch, put in the stitch.
And this is without consulting a high-risk doctor.
Yes, wow. Correct. So the patient had her stitch placed and she's now gets sent home on bed rest. And that was when I first met her. That was when we first connected. And I asked her, how long was your cervix at the end of your procedure? And she said, I don't know. They didn't do an ultrasound. I said, okay, quietly. And again, my goal here is to be your guide, your confidant, your friend. I'm like, that's okay. Like, I've seen it all. Like, we can get through anything, right? Any disaster I can take you through because I've been through something like it. So I said to her, okay, here's the deal. here's how we're going to handle this. First, I've seen, and I gave her data. Here's what I've seen women in your situation. Here's what the data says. The evidence-based medicine says that with the cervical length, that's this. Here's your likelihood of delivering preterm. So exhale. Let's get you off Google. Let me hear your fears. Let me hear your questions. Could her doctor have answered those? Yes. But I like to think that I'm able to give a little bit extra because not every doctor has the time to do this, even if they want to. So we made a game plan. And I said to her, okay, how are we going to advocate for you? Who's helping with your baby? Let's get that stress out of the way, right? Because when moms are pregnant with their second, they worry very much about their first. Yeah. And it's not just about this pregnancy. It's about this reproductive lifespan, right? Of your goals overall as in your reproductive career. And I don't think we use those words together enough. Because everybody's
I don't think I've ever heard reproductive career, actually.
Your reproductive career. Like, this is not like, oh, I'm a stay-at-home mom. Yay, I have 2 kids. Life is all cute. Like, it's a really freaking hard job. And so, you know, I talk to people about their reproductive goals in their career of being a mother or being, you know, trying to get pregnant or adopting or whatever your situation is. It's your reproductive career. Anyway, we had a conversation. I said, here's what we're going to do. We're going to get you a high-risk consult. Here's how you're going to do it. You're going to call the office. You're going to say, Dr. X, you put in my cerclage. I'd like you to send over a referral so that they've got the paperwork. You're going to then call the high-risk office. You're going to say, I had a cerclage. I need a follow-up ultrasound and I need a consult. And that's, I said, take a deep breath. They're going to talk to you. I said, and I want you to ask these 3 keywords, likelihood of, these 3 terms, likelihood of preterm delivery. I want you to ask about progesterone. And I want you to ask about what if the cerclage isn't in the right place. Lo and behold, patient goes in, she has her consult. She loves the high risk doctor. He spends an hour with her. So she advocated for and got what she needed from her doctor. He then did the ultrasound and said, I don't think the cerclage is in the right place.
Oh, no.
Which is okay, because I don't really know that it was so important anyway. For anybody that's listening, that's had a situation like this, if you've had a term delivery before, that's super protective against having a preterm birth, which is exactly what this patient had. So one sub point to be made here is that nobody looked to give her anything reassuring. Mm-hmm. They gave her a diagnosis. They gave her the risk factors it entailed. They gave her the intervention. There was never a thought to, let's talk facts. Let's talk about not just scary facts, but also things that can give you some peace of mind. Because again, we don't forget about me, because it's a really, really sore spot for me. But as a patient's OBGYN, we don't want our patients on Google either. Yeah. It's a disaster. It's a train wreck for everyone in the system. So we need to give patients reassurance, and we also need to give them the facts, even if they're a little scary, because that's what keeps people off Google, being fully informed. So she advocated, advocated for herself, had the consult, had the scans, her cerclage wasn't in the right place. Unfortunately, the high-risk doctor wasn't comfortable doing the actual exam with his own hands. Not sure why, but she was sent back to Dr. X, who put in the cerclage, which is okay. It's just an extra trip. So I pointed out to her, if you're getting sent on all these visits, if you're getting sent back to Dr. X, I promise you, nobody's worried about the baby falling out of you right now.
Yeah, exactly.
So Tracy, I wanted to ask something because it's being asked in the chat here.
Yeah.
And I think it's probably fitting with what you just said. She asked, how can we change this paternalistic mentality? So I think in the sense that the doctor knows more, and, we all feel that way, of course, going into it. And we're kind of conditioned, I think, as you were saying at the beginning, especially as women, to follow and play by the rules. And, if that's not our career path, we kind of trust whoever actually went to those schooling. And I mean, I'm not saying no one should trust their doctor. Of course they should. Yeah. But if you have concerns and questions and they're not really hearing you, or
I mean, that's how people end up on Google, right? Like you said, if you don't have full
information, totally. And I will say, to be honest, even though right now OBGYN as a field in general is becoming predominantly a female it's sort of female heavy right now. A lot of the subspecialists in infertility, for example, and surgical subspecialties in maternal fetal medicine are still sort of 50-50 male female. And as an interesting sidebar to the question about the paternalistic attitude, even a woman can have a paternalistic attitude. If
I
they're
was actually
this is what
literally, I was literally going to say that, because I was going to
Yes.
say, we know two amazing male, people.
Yes.
And actually mine, I love my doctor, my high risk doctor. I will say he's amazing. And so it's not a gender thing that we're talking about. We're talking
Yes.
about systemic.
100% right. It's systemic paternalism, really. And so the best way overall to handle a situation like that is to make sure, by educating yourself and empowering yourself, that you are aware that the doctor knows, and the doctor knows that that you are the consumer, right? And at the end of the day, you are still the client. And even though the doctor doesn't want to be questioned and their knowledge doesn't want to be questioned, a good doctor still wants the questions to be asked. And I think some of it is learning the language that helps to sort of dissolve some of the paternalistic defense mechanisms that doctors have, right? Like, no doctor wants to get sued. No doctor wants a patient to rate them with 1 star on, whatever website they go on. No doctor wants patients to complain about them. And the patients don't want to have to do that either. So everybody wants the same thing. So patients can enable their doctors to be sort of less paternalistic or maternalistic or whatever it is, to be less sort of like, to talk down to them, to speak to them in a way where they are dismissive, by saying, I want to help you, help me understand. How do I do that? And I think by trying to say something that takes the doctor and makes them your partner, that is empowering for both the patient and the physician, because then the doctor doesn't see them as a threat. And the doctor is reminded that the patient wants them as an ally, not just someone to yell orders at them.
Yeah.
Does that answer the question at all? Like, I think that can apply in a lot of circumstances.
And there's a follow-up to one of the mothers here, and I feel the same way, but she said she pushed her own self aside because she kept telling herself, well, they're the doctors. What do I know? They're saying I'm fine. I must be fine. And I can relate because, obviously Sam and I lost babies, and we were in a pregnancy that was told to be perfect, right, the whole way through. But we also had feelings at some point. I felt weak and stuff. And he kept telling me, oh, well, just take more iron. And I'm like, it's not helping. And he didn't do any additional testing. And at that time, I didn't know babies died, right? So I assumed, well, my doctor's saying these great things about my pregnancy. I've had a baby before. What am I thinking? I can't just keep going, and they're saying the same thing and they're really not doing anything. So I think it comes to that point, like the awareness that's why we speak about it so much. That there are these risks, and that sadly they do happen even to a low risk pregnancy, even to a healthy woman that goes to all her appointments, that takes her vitamins, reads everything. I know Sam talks about the courses she went to and everything. So I think that's part of it. We don't want to scare people, but knowing the reality of certain risks makes you think twice about questioning yourself. So makes you realize, like, I have to fight for myself.
Absolutely. And to your point, I think that very seasoned doctors and doctors who have had the misfortune of seeing a lot of bad things take it very seriously when a woman says in the 3rd trimester of pregnancy, or at any point, I just don't feel right. That, to me, it was the most frightening statement that any patient could make on a phone call. Immediately, something I knew that something was going to be wrong, or the shit was about to hit the fan at some point. So to give any woman who's listening now or ever any power, once somebody says that to me, so a doctor who's been there, seen it, that's a scary sentence to hear. And so rather than frightening the doctor, if your doctor is lucky enough to not be one of those people, then as a patient, I think it's super empowering and really good. Instead of having to be like, you need to listen to me, like something's wrong, you can even say, look, I'm so happy that you're reassured but I have this feeling that I cannot shake. And as a mother, I feel like I have to stick up for my baby. And I really feel that there's something going on. Can we as partners try to figure out together how we can get some reassurance or what we might need to look at further? Because then you're really getting your point across that something's going on, that you're not becoming adversarial, that you want to engage your provider as a partner, but that you both have to look together because something's going on. What could you do to examine what you're feeling? How could you get in? Maybe I could come in for an extra visit and we could sit and talk about what exactly is the situation here. And if you've got an intuition, you've got an inkling that something's different about the baby's movements. And look, I've had thousands of patients say to me in the third trimester, the baby's movements have changed. And hundreds, if not thousands of them have had no adverse outcomes. But, you know, when women say something's going on, something's usually going on. And that is one more piece of advocacy to give to women. Moms can say to their physicians, you know, oftentimes, and I've heard this many times from other mothers, when moms feel like something's wrong, something is often wrong.
Mm-hmm.
That's another great thing to say.
It's a good point. And another mother actually asked, how would someone know that both their OB and their MFM, you know, they're in consultation with each other, were giving horrible advice? She didn't know until after her son died, and then started Googling all kinds of things that really they weren't getting the best. You know, like you said, you have other things you can do. And so what are you supposed to do? I mean, I understand what she's asking. She feels like it should have been.
Yeah. How do you know what you don't know?
So that's a great question. So first of all, to give that mom some reassurance, the more eyes that look at your pregnancy, the more likely you are to be given the correct or good, I should just say not the correct, there's sometimes no correct answer, but the more eyes that look at your pregnancy, the more likely it is that you're getting a better scope of advice. So when you have a generalist and a high-risk doctor consulting, you should be able, for the most part, to trust what you're being told. And you know, if that doesn't feel right, can you go online? You can. I would strongly advise in situations like that, if you want to sort of reassure yourself, yes, you want to trust your doctors, then it's okay to go online and look up your condition, not in a chat group, not on Google, but to specifically search terms like evidence-based article, placenta previa, or ACOG, for example, like our College of Obstetrics and Gynecology, or SMFM, which is the Society for Maternal Fetal Medicine, publishes guidelines. And you can find a tremendous amount of recommendations in those publications that are really super layperson friendly. They're written in like real English for the most part. And so I would actually very often, when I would see a patient for consult, because people are usually overwhelmed, their heads are spinning, I'd print ACOG's compendium statement on topic X, Y, Z. So not to doubt your doctors, there's nothing wrong with doing a little external reading and just making sure things sort of line up. And then my advice would be, if you read something, again, not on Google, not in a chat group, nothing, because that's a disaster. If you read something where there's evidence-based medicine and something doesn't feel right, you say, you know what? I really trust Dr. OB. I really trust Dr. MFM. I really trust you guys. I'd like to just get a second opinion, if that's okay with you. Not even if that's okay with you. Sorry, look at me. I'm being a good girl. I'd like to get a second opinion. Just it's a work in progress for all of us, right? I had to stop apologizing to a website designer today. I'm like, stop saying you're sorry. I'm not sorry. I like blue. But you know, to say, like, I really would like to just hear one more. Do you have a colleague who I could talk to just to see what their thoughts are on what you've just told me? Does that help at all? And my guess is, and I really mean this, there are very few situations, especially in high-risk OB. There are so many gray areas. So to that mom, who I'm not speaking to directly and who I'd be happy to speak to directly after whatever, my guess is, even if she believes she was given the wrong advice or had an adverse outcome, the likelihood is there was not a complete inaccuracy of information that was given. There probably were some meaningful guidelines, some general information that was correct. It's really super rare for an OB and an MFM to I'm going to watch my language here because people don't know me personally yet, to really completely screw up recommendations. So it's okay to be angry at your doctors. It's okay to feel they've done things wrong. Anything that a woman can do to not blame herself is the most important thing to me. But I also want to offer that reassurance that, had you, wherever you are listening, gone to had a different OB or had a different MFM, it's possible that the advice wouldn't have been entirely different. And again, it's a case by case scenario.
Yeah. And as you said earlier, you are the client here, and you can
Correct.
vote with your feet. If you feel like you're not being heard, if you're just feeling, even if you're getting an explanation, you just don't understand. Right. And that's exactly why I think what you're doing with Blue Moon Perinatal is so helpful and so valuable, because that's what happens so often.
Correct.
Especially to parents like us who are now in, a high risk subsequent pregnancy after a loss. I mean, and in the stillbirth community, I mean, our parents are all over the research. I mean, we are reading everything that is published, because so few of us get answers. So few of us, understand, if what happened last time could possibly happen again. We're always on the lookout for new information and trying to learn and apply whatever it is that we can glean, to our pregnancies. And like you said, there's so many great areas. That was one of the things I was so shocked at. My first pregnancy, and my daughter Lana was born still at 2 days before her due date after a totally perfect first pregnancy. And I was so shocked to learn in my subsequent pregnancies how little we really know about.
Absolutely.
I was under the impression that women have been giving birth for years. Of course we knew all the science, and there are some very, very basic questions about pregnancy that we still do not have answers to.
For example, when we go into labor, what causes preterm labor?
What causes labor at all? Nobody
at all.
We have a friend who started a foundation to answer that question, the Iris Fund. They were literally specifically looking only at that question: what causes a woman's body to go into labor?
And we will go into that next week. We're going to do a full competent cervix week about that. I actually have a really great question in here from one of the people following us. She said she noticed that there are challenges with Acog and some OBs that like to follow the guidelines to a T, despite any updated information, especially new research that might be out. We talk about this a lot with the Measure the Placenta team, because these are mothers who have found that their babies died because of a small placenta, and yet they still refuse to measure placentas, even though there is a technique we know of now, EPVs, that Dr. Kleiman developed and willing to teach anyone, and it's all about, is ACOG saying this is needed, or it has to be sanctioned, so it seems like really difficult as a patient, especially finding out after a loss that, my son did not die of that cause, but I'm involved with the letter writing campaign because I feel like if there's any way to save a child, and that's something I feel preventable, the size of a placenta can be measured. And, there should be no reason a full-term baby should just die that we could have been monitoring and delivered a little bit early. A lot of these babies go to due dates, if not after due dates. Mm-hmm. And it's just so heartbreaking. So what do you think about that? I mean, I know it's hard. We don't have a lot of power as making something that's not ACOG approved.
It's very important that you ask that question, actually, because, when we talk about advocacy, so much of what we talk about is doing things that maybe not just forget about ACOG, but insurance doesn't cover, right? Mm-hmm. So we're talking about fighting two organizations here. And that is a very important point. The ACOG guidelines were written, and they're super, super loose, but they're to basically help doctors and patients have very and they're not so strict, but they give you pretty good guidelines to try not to do the wrong thing. for example, and they change, but it's to give doctors who are kind of doing things that are totally out there and totally wacky a signpost to kind of come back to. And from a doctor's perspective, and also just so you know, I've done a lot of like medical legal work. Acog's guidelines are really written for the doctors, and they stay loose to allow for some wiggle room. And so they've broken down things now in Acog compendiums into things that are based on like best evidence-based literature. So there's like, you know, this level of opinion, that level of opinion, the next level opinion. And if you actually look and dissect the more recently written guidelines, there's a lot of wiggle room. There's much more wiggle room than there used to be. And that is to allow for advances in research, specific situations. Acog is very afraid to write up a guideline that says you must do this, you must do that, because then any doctor who doesn't do this or that can get sued. So just for the people that are listening to know from a higher perspective in like sort of the, you know, the powers that be in Acog, they're super loath to say you must do anything. So that's something too, that's a piece of empowering information. Acog is a set of guidelines, helpful guidelines, guidelines really to avoid people practicing bad medicine. So if you look at Acog and you look at some of the things you're talking about, those things can be alluded to. There's no place that says you should not be doing this. There are a few situations where it says it should not be, but they're really rare, and they typically tend to protect patients. And so despite what Acog guidelines say, there is still room for extra. So for example, it doesn't say anywhere, despite the fact that there are guidelines, say for looking at the placenta. Let's just say we look for placental location at the 20-week ultrasound. We make sure it's not a previa. We make sure whatever. There is knowledge and information that's come out now. There are some blood tests that we do in the first trimester where there are markers where if they're abnormal, they can predict that the placenta might not work well later in the pregnancy. And it says nowhere in Acog that you can't assess the size of the placenta or assess the placental adequacy. And that's something that's really important. I think that sometimes, you know, if people go to a doctor or go to a practice, they go to the closest hospital or the practice that your friends all go to, sometimes there are bigger questions to ask that'll help you go to a doctor who understands how to use the Acog guidelines and who's using tests that are the most up to date and being done at the right times. So please keep in mind, again, if you're listening, that Acog mandates, if you will, are really to protect against dangerous things, not to protect against additional things.
That's a great
Does that make sense?
Yes, I love hearing it, and we will use that in the clip.
Yeah.
Yes,
But it's really, it's really
important.
true. It's to prevent like scoundrels from practicing super bad medicine. Like you can't just go ahead and randomly decide to induce someone at 35 weeks because they're whining, like, and they're uncomfortable, right? We all know that.
So there's a follow-up situation here. A woman who works a lot with lost families for 3 years now, and a lot of providers are not listening when the birthing person says things like even that the baby's not moving much. They even have them waiting somewhere, or you know, either if they bleed late in pregnancy
every day.
So she says they had them waiting in triage instead of immediately being checked in.
Yeah.
I mean, that's not really a question, it's more of a comment, but I did want to read it because
so I would in that situation, and I have to tell you honestly, I've seen a lot of women present with concerns of decreased fetal movement. I can only think of, and I am not joking. I mean, I delivered 4,000 babies during my residency alone. Like we had to keep track of numbers. So that gives you some idea of how many pregnancies and women I've seen. I can literally think of one patient who had a serious complex psychiatric disorder, who sort of used the fact that she wasn't feeling fetal movement to kind of get away with something, if you will. One patient, one, that's it. And she really had serious mental illness, and it was overt, and it wasn't something that nobody knew about. It was part and parcel of dealing with this situation that she wasn't feeling the baby move, and we had to deal with that. But except for that situation, women can say freely with that piece of information that I just shared with you to their doctors, I am concerned that this could be a pre-morbid event for my baby. I need to be checked right away. This is an emergency. My baby's not moving enough. Let's make sure this isn't a bad tracing.
Mm-hmm. Well, I
Say
can
it.
tell you from my experience, I called the ER and I had already said, I feel like he's changed. This was the middle of the night, so I couldn't talk to my doctor. And so I had already looked on Google, you know, looked up the articles, everything I could find that said 10 kicks in 2 hours, which is outdated. And I know a lot of people are still getting that actually from their doctors, because I have a TikTok reel that's going crazy and people are commenting left and right, like, about their experience. And some of them are saying, oh, but as long as you get this, I'm like, no, no, no. So I had to comment back to about over 1,000 people to educate, but I will. I've been on there every day. And then they also told me, you know, eat a meal and wait another 2 hours before you come in here. So there was the delayed reaction from the ER. Then I get in there by myself thinking, well, I'm worried, but I didn't think it was anything like this. So my husband was home and I was just like crying, and they're just, oh, don't worry, honey. And then they take their time to check me in, and then they finally get the monitor on my belly and finally hear the heartbeat. And I thought he was fine. No one said it was a bad level, but yeah, it was just like no immediacy. And now that I know about it, I feel so upset, because I thought if I could be there with myself now, I would be hollering and I would have been there immediately, you know, but you don't think that because no one tells you you can have a stillbirth at,
Absolutely.
I didn't know the word.
I wanted, so Anna, I'm so glad you brought that up, because I want to address it specifically with you and also with the bigger community. There is a time when there is a stillbirth where movement can change. There's some signals that you may or may not pick up, and a baby passes, right? There's an interval in there. And I have seen women come in saying something's different, something's changed, be seen emergently, have a really, really shitty tracing, excuse my language, get rushed back for an emergency C-section, and the baby will be delivered and will pass or will be severely injured. And so it's so important to me when, you know, hearing about a situation like that, that I want to give two messages, and they're separate messages. I wish they overlapped more, but they don't. Number one is to say, I need to be seen emergently. But number two, there is a real possibility that even if you are rushed in emergently, when you notice something, there's not going to be intervention to hand you a healthy baby. And so that should there's so much guilt that women who've lost babies carry. What if I had gone and yelled and screamed earlier? What if I had gone? So there is a narrow window when that happens. And sometimes, so that's really super important, because I'm saying two very different things, right? I'm saying go in, yell and scream, I'm an emergency, I need to be seen. But that very few times will that action necessarily mean that you will change the outcome. But it's the right mindset to have for your entire pregnancy. Because sometimes what will happen is, instead of coming and yelling and screaming and saying, I'm an emergency, you will be of the mindset where you might come in 3 weeks earlier and say, something's a little off. And all of a sudden that little off may start to become an emergency to a doctor. So it's just pushing the envelope back and back and back, so that we can hopefully, God willing, start to learn how to find that sweet spot where the mom is saying something is important, and we as physician can get in there and intervene when we can actually do something.
Yeah, I agree, because I think there are things prior to even that.
Yes.
Obviously, the movement is one of the very last things that are going to change, because your baby's starting to feel weak. And, you know, then of course, no heartbeat. Like, you don't, that's why we tell people don't use your Doppler at home, because that's not going to help the situation. Like,
no, I
if you
hate
feel
Dopplers at home.
go in.
Yes.
That's all I say. If you follow me on TikTok or anywhere else, you're gonna be like, that girl only says that all the time. I'm like, yes, what's so important. And I want to make sure everyone sees it, because unfortunately we're not being told that, and we're not being, I think, supported. and the way like family or community might question you, even like, oh, no,
Yes.
baby's this way. We always say babies did not slow down in the pregnancy. I mean, we have the same things, right, Sam? We have a million
no,
little
it's our
hashtags.
Hashtag know you're normal. Hashtag movement
Yes.
is better. Hashtag count the kicks. Hashtag always ask. And that's exactly what
Yes.
always ask. And the sooner you ask, the
Yes.
sooner that, you know, you're giving your doctors an opportunity to find out what's going wrong and intervene.
Yes.
And
I would
really
add
look at that emergent situation.
Yes, and I would add to that, Sam, when you do ask, don't say, I'm sorry, I just have one more question.
Yeah.
I don't mean to be annoying. You know, I don't, you
Well, that's
need-
our last hashtag. Hashtag use your mom voice.
Yes, exactly. And
You're
it's
so
very,
funny.
right? And it's very hard.
They're all
to
very
do.
good hashtags.
They're
That's good hashtag.
amazing. That's my favorite one, I think. But I saw your, you know, on social media, you guys have them when the mom is like shaking belly, like,
God, yeah.
I mean, honestly, like I just can't. There's no more. And I can, even when I say the words, I get a little like queasy. There's no worse phone call in the middle of the night than when someone calls and says, you know, I haven't really felt the baby moving a little bit. If your doctor or your group of doctors isn't up shitting in their pants when you make that phone call until you get to the hospital, you change doctors.
Yeah. I mean,
Yeah,
Mommy labor nurse had a great one today.
oh, yeah, she did. Mommy labor nurse. Everyone go check her out.
Go check out Mommy labor nurse. She
Our
had a great
favorite
one.
pregnancy
Oh,
account. There's actually a very controversial comment here. I will read it because we are that type of group.
Yeah, go.
We don't shy away from controversy.
So much of MFM is judgment calls and their own risk tolerance to specific risk. But as a patient, how do you determine that a provider for a provider until you're in a pregnancy with the provider? So I guess she's just trying to say is, I mean, we know that there's another area to it. And that's what the whole ACOG questioning comes in too, because we always wonder, like, do they feel protected by, I followed the guidelines, and so therefore I don't want to do these extra things, and I don't want necessarily pass, you know, do more tests on every woman and find more things that might become on me, you know, right?
Yes.
And delivering a
Yes.
baby too early, like a preemie, because they feel like the mom's saying, oh, baby's not moving, but they don't see anything else, you know.
There is far too little education about how to, and I've said this for years, and I hope that at some point this is going to be something that we're taught, but OB residents, when they have their lectures every week, need to be lectured by medical malpractice attorneys and defense attorneys. Everybody's so friggin' afraid of getting sued that there are ways to attend to patients' needs and doubts while trying to also stick with the ACOG compendium guidelines, where you can deviate from the norm and be still addressing people's concerns. And if a woman is saying, for example, they do not feel fetal movement, and this is just one example, but they come in, they're 36 and a half weeks. They have a beautifully reactive non-stress test. The biophysical is fine. They look at the ultrasound. The resident says, look, you see the baby's moving and you still don't feel it as a mom. You cannot send the patient home. And I can't tell you how many times. I know they do. But then as a patient,
I was going to say, because Tracy,
yeah,
there's too many moms we know for a fact that had that and actually also didn't have the most reactive thing, or they were like given something to drink.
Yeah, I know.
Or told to jump
Our
up
team
and
was
down.
the other day, they had a BPP and the ultrasound tech had them get up and jump around because the baby wasn't moving enough to get them to react on the BPP.
To have some.
We were just like, what?
I know. And I will tell you honestly, to that point, I'm glad you brought that up, because I will tell you that I've seen all those things happen, and 95 to 96% of the time, it's been fine.
Exactly.
But the times when it's not, it's not.
Yeah.
And so again, this is about very much in a partnership way with your mommy voice. Like, I have to talk about that mommy hashtag for a second, because I think it's friggin' genius. Because if that's
well, we're actually going to change it because we know it's not inclusive, but it's
Right.
I have to give credit also to Preeclampsia Foundation, because they're the ones who came up with that, starting with preeclampsia. But we've definitely
okay. So listen,
Use
if
your
it came
parent voice.
from them, that's great. Because in my mind, every single pregnant patient has preeclampsia. Like, I mean, I just, like, people used to make fun of me. They're like, she's preeclampsia, right? I'm like, yes, Yes, yes. Atypical preeclampsia, yes. Anyway, but everybody always has preeclampsia, but they do. I mean, for the most part, they always usually have preeclampsia. Anyway, I think that again, it's, there's a mommy voice that works and a mommy voice that doesn't, right? There's the mommy voice that works like, put that friggin' piece of thick chocolate down. Like, you're making me crazy. I can't stand you. Like, that mommy voice doesn't always work. And we shouldn't have to use the like psychobabble, like, let's see what you're doing. And how can I positively reinforce you putting that piece of chocolate down? Because you're such a good kid. And here's something else to distract you. I got to be honest, that's kind of the mommy voice we need to talk to our care providers with.
Mm-hmm.
I know it's not fair. I know it's bullshit. I know we shouldn't have to do it, but I do think there is a tremendous amount of gain that we can make as patients by engaging our physicians that care for us in a partnerly sort of way.
No, but I agree with you. And I think it's the whole, you get more bees with honey.
Yes.
Obviously, they're still human beings, and we're not talking, and we do not want to make it seem like us against them in any case. That you should have a teammate. You should have someone
They
that
are
you believe is
Yes.
listening, and
So Anna, to your point, if you're that mother who's saying, yes, we see the baby move, you got to go home. This looks fine. It's okay to use your, psychobabble mom voice and look that doctor in the face and say to them, yes, but how will I know if I go home if the baby stops moving for real? I can't feel the baby moving now. And I guarantee you, the resident, the nurse, the doctor is going to look at that mom with a blank stare and no answer.
Yeah.
How am I going to know when the baby really stops moving? That sentence is going to scare the shit out of whoever hears it. And that's the kind of advocacy that I want to teach people how to do, because it's not being mean. It's not being defensive. It's the truth, right?
Truth, exactly. You can't.
And again, that's what I always tell the annoyed resident who calls me. No, and I love residents, and but I'm just saying, when a resident calls and wants to move their patient off the labor floor because they've decreased fetal movement, but a biophysical of 10 out of 10 in 10 minutes, and I say to them, how is that mom going to go home and know when the baby really stops moving? I hear their eyes roll. And then they're like, oh, you're right. Right? So
what can a mom do at home? And if a mom is saying she's not reassured, that's one of the keys that we're finding in other countries where they're implementing very like
protocols,
yes.
like clear protocols, like how
actually what you should do step by step, so that there are lists and charts.
Exactly. That's on the checklist. After you do all the tests, even if they come back perfect, you ask the patient, do you feel reassured? And if their answer is no, you do not send them home.
Absolutely right.
There's something to that, right? Like we've been training pediatricians for generations, right? If a mom with a baby comes in and she says there's something wrong with the baby, a nonverbal baby who can't express yet, and you can't find anything wrong, you should listen to what the mother's saying, because she's probably is onto something.
And you can write. And for physicians, to educate physicians, you can write that down in a note and not be sued.
Yeah, exactly.
You can write down, the mom remains concerned. I have reassured her these are the tests that I can do today. I will continue to explore the topic. And no, there's no humility in saying, I have asked her if she'd like a second opinion. Turf it to somebody else, but it's okay to say you don't know in a note.
Exactly.
I will say that I learned a lot of this after loss, of course, because I realized how urgent and serious it is. Even in a normal pregnancy, things can turn, and you have to trust yourself. And so with my rainbow pregnancy, I had a couple of times, but one specifically where I knew I had an infection, and they kept telling me, no, we've already tested for all the usual ones, kind of thing. And so I'd come in, I think I came back again to my next appointment. I said, and I had been going like every week at that point, I think. And so I was crying, and the doctor's other doctor that would see us was just like, well, what else can I do to make you feel better? I mean, there's one more test, but I don't think you have that. And I'm like, well, please run it. Anything you think of, like, just do it. Cause I don't think we found it. And next day she called, oh, you were right. You have a GBS infection. We need to have this medication and everything will be fine. And, I'm like, what? I had a cerclage in. So I thought, I didn't even want to research it, but I know that was dangerous. So thank God, my mommy voice got a little bit more hysterical at that moment, but
Yep.
I was just like, I'm not leaving. And then we also had a low fluid at the last appointment. And my doctor said, normally I would send you home, just tell you to drink water, but I know you guys are not going to be relaxed. So he let me stay overnight and put me on the fluids and everything. So I was so thankful. I had the monitor. I actually slept for the first time in 36 weeks, and then next day they try to send me home. They were like, you're good now. And I'm like, I'm not leaving without the baby this time. You could either have him delivered now or just like
stay in this bed.
I was like, I'll pay for it, whatever it takes. My husband was there. He says, we'll pay for it if insurance says no, because my doctor said, I don't know if insurance is going to approve this if it's nothing called for, right? And I'm like, I don't know, but if I go all the way home, which I was an hour from that hospital, all of a sudden my baby stops moving or something, the fluids get low again, how am I going to get there in time? I said, no, I'm not doing this, doctor. Like, please, like, we were just like, literally, we're not leaving. We weren't getting up off that bed.
Good girl. I mean, honestly, like that's what we all.
Yeah, I mean, that's what I know I needed to do at that point. But otherwise, earlier, Anna would have said, okay,
sure, I'll go home.
It's normal. I'm going home now.
Yeah.
And I want to get across. Yes. And I want to get across to everyone that's listening. The overwhelming likelihood here is that if your doctor tells you everything's okay, everything is okay. Your doctors are, nobody goes into OB because they don't want to do what they're doing. Do people get tired and cranky? Sure they do. But people go into it's really like incredibly hard these days to get into medical school, still to stay in medical school, to do an OBGYN residency. Like it's really hard. So people want to be there and they want to be doing the right things. It's just that the system is working against them now. And lots of things are working against the physicians and against the ability to really care one-on-one. And so that's why it's so important to look for other ways to supplement. And I just want to take 2 seconds to address the fact that my goal with starting.
That was my next question for you. I was like, we're almost at 9 o'clock. Tell us about Blue Moon Perinatal, please.
Yes. So
we
honestly,
don't do any more questions. Okay, there will be a part 2 for you guys because I can't even tell you. I mean, we've missed over 25 comments. We were so behind.
Oh, I want all the comments.
No, but we'll have the comments, but we'll go back and answer some. But we'll also have her back. So guys, don't worry if I didn't.
All right, good. Like I'll stay up. We could do them later. We could do them at 11 o'clock.
We could do another hour.
We could start scheduling another monthly clubhouse or something.
Yeah, there you go. Tracy will be back, everybody. But
if there is another format that I have to learn on social media, I'm going to shoot myself in the head. Like if anybody tells me I have to get TikTok, I'm going to cry. So I'm not.
You are getting on TikTok, and you're also going to get on Clubhouse.
Somebody said something about Spark the other day. I'm like, isn't that a dating app? Like what? What are you talking about? And they were like, no, that's Tinder. I'm like, oh, okay. Like I'm really like, honestly, at this point, I'm going to wind up.
Can I ask one more sensitive question just because I like it. And I think it's important to say a lot of her mom clients and friends, I guess, are Black mothers. And they're saying they're worried about presenting as an angry, loud Black woman. Obviously, we know there's racism in the system. That's why they have worse outcomes right now. And that's already been pointed out clearly. So what should they do to be pushing the envelope and not stay quiet like they think they need to, or
So first of all, there is nothing wrong. God love a good angry Black mother. I got to be honest. Like my first answer is I could care less. Like if you think you come across as an angry Black mother, God bless. Like the world needs us all to be angry Black mothers right now. That's my first point. However, if you are an angry Black mom and you're not comfortable with portraying that picture, okay, I can package you and make this a nice, lovely thing and kind and stuff. And you can just say, I actually don't even want to take it any further than that. You can be who you are.
Yeah, it's not their problem, obviously. It's
quite frankly, that's right. And I really do believe that, again, the one thing I will say is angry Black, angry white, angry Latina, mother, whatever, whoever, surrogate, whoever you are. Again, I do think that unfortunately, because the system is so loaded against the doctors and the patients right now, that I do think that in any situation, trying to take the anger out of it and trying to do whatever you can to engage your care provider, midwife, doctor, high-risk person as your partner, and to spell out, I want you to be my partner in this, and then say whatever it is that you want to say.
Yeah, it'll diffuse the tension a little bit, right? Tensions are
Yes.
very high.
So
Everyone
yes, so A, if you want to go be angry, whatever, go for it. But I do think that there is value in knowing that the doctor, believe me, I can promise, the doctor feels the system is working against them as well. The doctor doesn't necessarily want to be providing substandard care if they are. So I think that just trying to make sure you stress that theme of partnership is really important, if that answers the question at all.
And I love what you said earlier, you say to your doctor, help me understand, right? Like
help me, help you, so that we can do what we need to do together.
Yeah, we all have the same goal.
Yes, everybody has the same
Living
goal.
happy, healthy baby and mommy, and
That's right.
absolutely.
right. One
There are
thing
too
I wanna
many
say-
questions on here. I'm sorry for everyone who was giving us such amazing questions, but we will definitely answer them later, or if not, we'll bring her back to answer the rest, because there are some really good ones in there.
One other thing I really just was really important to me to point out about Blue Moon is that I want to just speak for 2 minutes about sort of what this means on a much bigger picture, much larger scale.
yeah.
Because right now, Blue Moon, unfortunately, like I couldn't get malpractice insurance because people are like, well, you're not really practicing medicine. I'm like, I'm practicing actually the most important part of medicine. It's like the left out part, right? And so because I had so much trouble getting my own coverage, these services are not provided by insurance right now. And so I find it deeply, deeply upsetting. I know it's a temporary thing, but I do find it deeply upsetting that right now my services are out of network. That really truthfully like kills me. I've always worked in a system where I care for patients who are underserved, uninsured, don't speak English, that's critically important to me. And my hope is that when Blue Moon is bursting at the seams, it will be clear that it is a patient satisfier, that it is a doctor protector, that it protects against litigation, and it's a system. It makes a
full system. Exactly.
100% that it is
Win-win for
equality.
everybody involved.
Yes, that it is.
I know you're not a therapist, but in a way it does help with the mental health aspect of care, which we of course are failing in. And someone mentioned in the comment earlier, but we didn't get to squeeze that in, but she thought we do need to focus on that, especially for
Yes,
mother. I mean, in pregnancy or after loss or after postpartum, whatever the case they are in.
yes.
I think, unfortunately, insurance doesn't normally cover any.
Well, the good news,
people, but
yes, that's true. But the one silver lining about COVID is there's a lot of therapists available now online that actually charge less, and you can sort of play around a little bit. There are services online where you can access mental health care, things like Talkspace and apps, and where you don't necessarily have to, get a really expensive therapist who's out of network. We can talk about that. I
think what you were kind of getting to, though, is there's a privilege in being able to even access someone like you. And
correct. And so eventually, I really do believe that this will be seen as a quality measure for institutions. And if that's the case, and this is adopted, I'm a highly overqualified person for this. I can help, 6 mid-level providers handle 1,400 pregnancies in a hospital system where people don't have insurance, don't have money, so this idea is something that I'm not looking to keep here. This is something that I need to expand, and I know can benefit hospital systems at a much larger scale. So this is just for now, because I won't be comfortable with this being the end all be all. This is not my end game.
Yeah. And that's what makes me so excited about what you're doing at Blue Moon, because again, I mean, you have seen firsthand where the gaps are in care, and you have both the clinical expertise and the ability to be, a reassuring provider. Like I loved when we first spoke and you said it was kind of like having a best friend who's an MFM and a therapist. Like
Totally.
you have all of the training, you have all of the knowledge, and like you really understand what patients are going through and how to work that system, and you understand the doctor's perspective. And
I've been that patient.
Exactly. You've been the patient and you've been the doctor. So
I've been the anxious patient with the therapist patient. Like, I mean, I've been a NICU mom, I've been a preemie mom, I've been like all of the things. And, again, it doesn't have to be like, eventually what this care model can be is someone medically overseeing the advice, but it has to just be someone who really cares. And that doesn't have to be a perinatologist everywhere. It can be the perinatologist overseeing the medical input, but this is something that belongs to everyone. And that is, I really will not stop until that's the mission that's been accomplished.
I love it because it's true. Everyone needs to have a reliable resource they can go to with questions that will help to empower them with the information and the knowledge that they need, right?
Yes.
Somebody asked earlier, how do we know what I don't know? It's by having somebody like you to go to, right?
Correct.
Say, this is where I'm at. This is what I'm worried about. And you could say, well, these are the risks you need to know about. These are the questions you need to ask. This is the way, as we talked about so many times tonight, this is the way that you phrase that in order to, break down those walls and get your providers, to work with you.
Totally.
Yeah. So tell people where can people find out more about Blue Moon? I know you are on social media.
So I'm on Instagram, and I'm at it's really all the same. It's bluemoonperinatal.com. I'm on obviously on the internet, www.bluemoonperinatal.com. I'm on Facebook. I have a page, and the links are everywhere. It's all the same. It's all Blue Moon Perinatal. My sort of packaging in terms of how I want to offer my time to people is under construction. So if what you see is not on my webpage, and you want to reach out, just reach out. And thankfully that I can still triage, sort of like create your own sort of situation. I just want to start getting in gear and helping as many women as I can.
Exactly. And then so like you prove the model works, right? And
100%.
Elsewhere. And the other thing I wanted to mention too, so we of course will be tagging you in all the posts and stuff like that. So anybody who's following Push, you'll be able to find your way to Tracy very easily too. I also wanted to mention that Push on our website, if you go to pushpregnancy.org/advocate, that's our advocating for yourself page. It includes a lot of the tips that we talked about tonight. I think I'm gonna actually have to go back and update with some of the things some of the advice that you gave. But one thing we have there new that we just recently put out is a list of questions to ask your provider. It's actually awesome. It's 11 pages. It is very thorough. It is very, very thorough. So it will give you questions to ask throughout your entire pregnancy, to try to again fill some of those gaps, to ask things that you wouldn't necessarily think to ask about, and to make sure that you're covering all your bases, and that your doctor again knows that you are paying attention, and that you want to learn, and that you want to be a partner, that you're not just coming in to just accept whatever's given to you at face value, that you're an active participant in this pregnancy. You, your baby, and your doctor are a team. That's how Absolutely. We get babies here safely, and we get parents and babies home safe together. The last thing I want to mention, I don't know, Tracy, I don't know if we talked to you about this. The big push to end parental stillbirth in October, we are marching on DC. We're going to push 23,000 empty strollers past the steps of Congress.
Oh my God, can I come?
I hope you will. I was about to ask, would you come with us to DC in October?
Yes.
We would.
Oh my God, yes. Can I carry my burning bra on a stick?
Yes, you can.
Of course. I'd be honored.
Yeah, it's kind of like we're hippies, we're like women power. No, but we do think it's a family affair, and we do want all of the providers there as well. Anybody Absolutely. Who cares about a family, it doesn't have to be someone who even knows a pregnant person at the moment. I don't even know if I know one, but I'm doing this for the future of my future grandkids too. We wanted this all to improve. We don't want anyone to continue to have a bad outcome, bad experience, and we want that for everyone.
And it is so importantly a way to honor all of the, the losses that you guys have suffered, that other moms, other families have suffered. It really is a legacy to them. And that's so, so important.
Yeah, that's what we always say. This is the only way left to us to parent our child.
That's right. And it is really a gift that will,
love.
God willing, we'll just keep giving and giving and giving. So
Absolutely. So yeah, so the website for that is thebigpushmarch.org. Again, it'll be linked all over the push pages and stuff like that. We're about to, officially kind of launch everything out there. But yeah, it's a call to action
Awesome.
for anybody in power, whether you are a government official, a public policy person, somebody in a leadership position in ACOG or SMFM or anywhere in medicine, to say, we need to make stillbirth prevention a priority.
Yes.
And we are asking for, some legislative measures for support, from our government officials, which is why we're doing it specifically in DC. We're looking for the Shine for Autumn Act, which is improving stillbirth data collection and research, for all the bills that are part of the Momnibus that are improving so many different aspects of maternal health. Again, because these issues are intimately linked, and we're really proud to be building a coalition. This is not a push event. This is an event that's being put on right now. We've got 30 something partner orgs that are in there with us planning this thing out and asking people to come and show their support, because again, this is something that touches everybody, and sadly no one is safe from stillbirth. Thankfully it is as you said, a rare event. 99% of the times things will be okay, but that 1% of the time that it's not, stillbirth is claiming more children's lives each year than prematurity, SIDS, car accidents, guns, drowning, fire, poison, flu, and listeria combined. And yet most families are never hearing that word until it already has happened to them.
Can I ask one more question, Tracy, because we're on the stillbirth talk and someone did ask earlier.
Yes.
Do you think a lot of providers don't think stillbirth is, first of all, preventable? Like, I know there's a feeling of like they did everything they could and they don't want to feel like they dropped the ball, because I feel like when I lost my son, no one wanted to talk to me about it or how it happened. It was just like closed case. We don't know, your baby was healthy, but we're so sorry, try again kind of feel. And I think even in the care, and that we're not all getting told about fetal movement monitoring and like how to actually lower risk as just a normal pregnancy. I think it's a feeling of like, that's not going to happen to my patient. And if it does, it's because it was something not preventable, maybe.
The answer is yes. I think and again, I'm one of those physicians. Yes, the answer is yes. And because I'm a high risk doctor and I have to solve and untangle mysteries, I'm used to trying to figure out things and worrying about markers that come up. But yes, I think that sadly, most of us in the field are not taught that we should be trying to look out for stillbirth prevention. I think that 100% needs to change. I think that needs to change at the very beginning of educating OBGYNs. Very early in training. It should be part of core curriculum and residency programs. And it probably should go all the way back to OBGYN rotations in medical school, because medical school students that rotate through OBGYN become ER physicians and internal medicine doctors and specialists who may see pregnant patients. So I think that it needs to go all the way back to probably medical students, quite frankly.
And the second part of that is, do they know the effect on the family? How long-term and how severe, and all the, postpartum and the depression and the long-term PTSD trauma. So I feel like that's why we talk so much. And I know we're not always getting to talk to them. Hopefully we can get into those places and actually speak to them also, because I think they need to see like, okay, we're talking less than 1%, but that's still 23,000 people. So if we can at least stop half of those people from this suffering, lifelong situation, then that's worth your time. That's worth your little extra fetal monitoring and movement training, and talking about that with your patient after 20 weeks when they're actually going to be able to use it, not just giving them a pamphlet at the beginning like mine did when I got pregnant. 8 weeks,
absolutely right. That's absolutely right. I mean, obviously it's no outcome that any doctor wants, but I do not think that unless you have experienced it with a patient, and then you follow them or them or you have a personal connection, the most caring of OBs probably would be appalled to see the long-term sequelae of a term stillbirth. I have always said I've seen a lot of horrific. I mean, I have things that I could have nightmares about for the rest of my life stored in my, in my memory. But I always think to myself, how does a woman with a term stillbirth go on? Like, how do you go on? How do you get through an entire pregnancy? How do you deal with that for the rest of your life? I don't think that enough doctors, family members, people view that as a loss of a child, of a living child, because that child lived and its story lived. And yeah, I don't think that we have any idea.
You don't.
I really don't.
This is Owen's bear.
Oh.
We didn't have him last time, and Sam asked.
Where's Owen Bear?
He's the size of Owen, a length and weight as well.
Length and weight.
Oh,
An original.
I think that is such an important mascot. I hope he shows up at every event.
He's at most of everything, except for I try not to bring him to these because these are more educational, but it is an educational moment. You guys should
Maybe
know.
he should sit in a stroller at the march.
Yeah,
He definitely will be.
Yeah.
Okay.
He's
We're
kind
gonna
of
have a lot of we say they're empty, but there will be many teddy bears.
That's right. That's right.
I think that you're spot on, because not every doctor will have a stillbirth right away, right? It might take many, many years before you even see one.
Yes.
And so, of course, in that one case, you say, oh, well, you might even look through it and say, well, there was nothing I could have done. And chances are maybe not. But you still should know that you absolutely did everything. And the patient also should feel like they knew everything that needed to be done. And like,
yeah.
And I will also add, and I will also add that what you guys are doing is amazing, because for people who've had a stillbirth in the past, for doctors who do see those patients, I still think the magnitude of the risk psychologically, emotionally, physically to that family is so dramatically underestimated.
Oh, absolutely. I mean, the data shows if you've had a previous stillbirth, you're 5 times more likely to have another compared to mother that hasn't. And like you said, the risks span the whole spectrum, because even if everything is fine physically in the pregnancy, just the immense amount of stress and anxiety and PTSD that families are experiencing introduces its own levels of risk.
Absolutely.
That's why we're bringing the Rainbow Clinic.
That's why we're bringing the Rainbow Clinic.
And on top of that, I just wanted to say that figure did scare me big time when I was pregnant again. And I just had a regular, high risk doctor, but not like Rainbow care. So I didn't have like the emotional side, like, the empathy. They were very nice, but they didn't have that kind of level that we're going to offer. And like Tommy's in the UK, we see like all the stuff that they're doing, and they actually are having a lower rate with these high risk situations with these mothers that should likely have more chances of it happening, and they're actually doing great. So I almost feel like that statistic itself is kind of a cop out. It's like, well, we never found out the reason for my stillbirth, so of course they didn't know how to do better. And I didn't have the same provider, so that new provider didn't even really look back at the old one. And there's a lot of holes there. So we don't accept that. We think if you're pregnant again after loss, you obviously are going to feel scared about the situation, but you do have options. You can go to a Rainbow Clinic, hopefully, or you can just get empowered with information. Have someone like Tracy look over something that might be making you nervous. And I really feel like you're not necessarily going to be set up for a second loss. I don't want anyone to have that dread of your pregnancy. We already worry enough, but it's just understanding like what went wrong and what can we do differently. And if you don't know what went wrong, then maybe you should find that out before you go on your journey.
Yeah. And that's really at the Rainbow Clinic specifically, that's the first step. When somebody comes in, the first thing I do is really put everything they've got into figuring out what happened the last time. And of course, not everybody's going to have access to the first Rainbow Clinic at Mount Sinai, where Tracy trained in New York City, but we're hoping that eventually they'll be around the country. And in the meantime, if you can find somebody like Tracy to be on your team, to help you figure out the right questions to ask to help you get the answers you deserve, that can make a huge difference.
And Sam, just one point that I do want to add, I think patients very, very often don't realize that they can go and get a preconceptual consultation with an MFM. So go get your records, and before you get pregnant and have to walk into the Rainbow Clinic, go to a high risk provider and say, here are all my records. Help me figure out what went wrong and what I can take in. What tests should I do before I try to get pregnant again? What tests should, like, maybe there was something that they'll discover that they say, wow, you had X, Y, or Z medical issue. Let's get this fixed before you try to conceive again. So please don't think you can only go to an OBGYN when you are pregnant to get those answers. Great. I'm glad you said that.
That is such a good point. You absolutely should be seeing your OBGYN and MFM if you're a high risk patient before you get pregnant.
Yes.
There are a lot of things that you can
with all your records. Yeah.
Records. And the Rainbow Clinic will be doing that too as well. So even
Amazing.
if you don't live locally, you could, if you wanted to take a weekend in New York City and come meet with Dr. Stone.
Also, if there's any provider watching, we do have the Rainbow Clinic training available, and we would love
it's so good.
share that out.
Thank you. Do you watch it?
Oh my God, it's so good. It's very triggering.
Thank you.
Great.
Yeah. Imagine good for us recording.
I mean, I'm sitting there with like a box of tissues, and my husband's in the other room, like, what are you watching? I'm like,
it is very sad, but I think it's very informative. It's for providers to really understand the mindset of a parent after loss.
It's amazing. Amazing work.
Thank you for saying that. That means so much to us.
Yeah, it's fabulous.
Are we gonna let her go now, Sam?
I know. No, we can keep you all that crazy, but yeah, you definitely.
9:30. Should we get the wine? We can relax. No. Thank you so much.
I'm just so glad I made it through that social media glitch.
Yes, we good to go.
You did amazing, and we just got so much information. I think we got through actually most of the big hitting questions. There were some more specific ones. I'll let you go back and you can comment. If
you know what? I don't know if there's a way to do this, but even if you wanted to through push, if you want to email me the questions that came up in the chat, and I could even write down some, brief answers, send them back to you, and you could forward them along to whoever asked them. I'm happy to do that too. Cool. I mean, I may be just cutting off. Yeah, I hope I don't cut off another segment to do, but
no. There is not much more, but the main thing was about being monitored and told that your baby's okay. And for most patients, that means they're okay forever, like for the rest of the pregnancy, because no one tells them that means you're okay only right now.
Yeah, that section that we saw right now is not predictive.
And even some of them are being told it's okay, it's good for 2 days.
Right.
Which is not really right.
So non-stress testing, the classic teaching is that when you have a reactive non-stress test, your baby probably won't die within the next 48 to 72 hours. That's what we're taught. And then if you adhere to that, which is already like a troubling statement to me to begin with, if you adhere to that and you then hear that people have weekly monitoring, like what the hell is weekly monitoring for? It's a freaking joke. So if you're getting weekly monitoring, please ask your doctor, why am I getting weekly monitoring? Because there isn't really a ton of rule for that. But I've, there are several moms I can think of just off the top of my head that had, reactive NSTs in the morning and came in at night with the stillbirth. And that's not to say
my daughter was dead 6 hours later.
Right. That's not to say, again, I don't want people to feel like, oh, I had a reactive NST, I have to go home and worry. But it's one piece of a bigger puzzle. It's one piece of a bigger puzzle. And so, always,
that's what we always say.
If you have an active NST, if you go home and you feel like your baby's not moving, something feels weird, go back. Just go back. Just because it was fine earlier doesn't mean it's fine now.
And I promise you, Sam, also, when you go back, people start to take notice and start to get worried.
Exactly. That I know that, again, with the international protocols, that's one of the things they look at is this recurrent, altered fetal movement. That is a big red flag. So
yes, I'll give you the last question just so everyone feels happy that we got to it. I think it's the last one. Good. What do you feel about the inductions at 37 or 38 weeks after a prior preterm stillbirth? Should that decision be made by the parents, which I think ACOG is sanctioning now, that if you've had a prior loss after 37 weeks, along with anxiety, I guess it can be done sooner. Do you think that's okay,
oh yeah,
we have the word of God? I don't know.
First
let
of
us
all,
please have our babies.
First of all, and I know that like there are lots of advocates for, like I follow the Down to Birth show, and I'm all about spontaneous labor, but in my,
we didn't even get into that. Oh,
no,
darn.
but as a perinatologist, in my mind, no pregnancy should extend beyond 39 weeks. I'm kind of kidding, but I'm kind of not. In terms of stillbirth, there is no question that irrespective of Acog guidelines, I worked with the person that wrote the Acog guidelines. And if you write a note that even let's say 37 weeks, which is kind of a little bit of a no-no land, right? Even at 37 weeks, if you have fully informed the patient of the 1 to 2% risk of transient tachypnea of the newborn because the baby's being born early, but because of the emotional duress of the patient, this was considered that the patient's preparedness for labor was considered. So for example, you don't want to have a C-section and an injury to the baby. As long as a physician is documenting thoroughly the risks and the benefits of said procedures, I think that it is absolute torture to go beyond where you lost a baby before. When that falls into,
trust me,
yes,
mine was 32 weeks. So I had to get all the way to, we made it to 37 and a half, but every
That's
week
right.
after I was like, please, 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 please.
That's
I don't
right.
care. I will deal
That's
with
right.
the preemie situation. I mean, I know that's not a good thing, but
That's
I
right.
was really, really nervous. And so he said, well, let's get to 39. I said, no. That we ended up saying
think,
something about 38, but my
yes,
son actually started, I was contracting. And so he said, okay, fine. We're at 37 and a half. Let's do it today. And I'm like,
yeah.
we're having him
I mean,
today.
look, in a perfect world, that number would be 38 weeks, but if it depends on the circumstances, and it depends on, I counseled a client yesterday who was saying that, well, I said, if you go in at 37 weeks and 3 days and your cervix is 3 centimeters dilated, you had a prior vaginal delivery with your stillbirth, I don't think anybody's going to mind sort of getting things going a little bit early if it's going to save you 4 days of incredible duress, which is not good for your baby. So absolutely, documentation. This goes back to ACOG. It's guidelines as long as physicians are documenting risks and benefits and writing a good note, and patients are signing forms that say, I understand, I consent. Then you've got a team that is making a decision together.
Yeah, exactly. And that's what we always say. It's informed consent, right?
Informed
Parents
consent.
we're not dumb. We understand there are risks. We understand there are trade-offs, but we need to know what those are in order
That's
to
right.
make an informed decision. And if we're working with our doctors as a team
That's
to
right.
learn what those trade-offs are and decide what's right for us, like that's an empowering pregnancy.
That is right. That is absolutely right.
Well, thank you so much, Dr.
Thank you,
Tracy.
Tracy.
I actually think we got to everyone's questions. So
Oh, good.
appreciate
Oh,
you.
wow. All right.
Yeah, and if
Woo!
not, don't message me. No, just kidding.
Good. Okay, great.
I know you
Perfect.
forgot one, but I think we got most of them, and we appreciate your time and all your
Do you want to give me the last one? Is there really one more?
No, I was just
Okay.
joking. I think we're
Okay.
good. There's a lot of people who are wondering why the training and the whole fetal monitoring, the protocol, that stuff is not done like the same across the board at every place you go. And I mean, obviously it's just because we don't have proper protocol, but
Yeah,
That's
there
right.
are no stillbirth prevention protocols in the US.
None.
There
None.
are none.
but that's why we're going to do the big push, everybody. So
That's
join
why we
us.
need a big push to say we need this. Other
right.
countries are doing it. We can do it too.
That's right.
It's time. It's time.
Absolutely.
Thank you.
I'm so happy you had me. This was so awesome. And I hope that everybody watching got what they needed. And I'm here. So
Right. Yes, exactly. Don't hesitate to reach out to Tracy. Don't hesitate to reach out to us. And we're definitely going to have you back sometime soon to do
Awesome.
another one of these or
That's
Clubhouse.
great.
We'll train you. We promise.
Okay, perfect.
Good
This is
night,
pretty good.
everybody.
Thank you
Thank
so
you.
much,
Oh,
guys.
are we going to do this again?
Okay. Yeah. Put your
Part
hands
of
up
it.
because we're going to
Where's my
going to write Shine for Stillbirth on your hands as a, what do you call it? We're making some viral pictures.
You're not explaining it well at all.
No, I'm not.
Everyone who's watching, remember that we're still doing the photos for Shine for Autumn Act. You put Shine and the hashtag Shine and then a child's name that you're remembering, or just put Stillbirth and post that on your social media, hashtag Shine for Autumn, and make sure you tag them as well. They have the Shine for Stillbirth account now. And we would
Okay,
love
Anna,
to
send me
also
all my
tag-
instructions.
Yeah, I'll give you all instructions, providers, friends, anybody can do it. And we want to make sure that everyone is talking about this act so that when it finally goes to the Senate, they see this strong support. It's a community issue. We all want to support it. So please do that for us and for any baby that you're remembering also. But we did ours to start it off. I did my own one, and then it just kind of flourished and everyone's doing it. So we're so happy to see the support of not just, you know, obviously the mothers that we all want to see our babies' names everywhere, but there's dads and grandparents and, you know, friends and cousins, aunts,
Uncles, and
kids.
it's especially meaningful when we see our providers, our doctors and nurses and doulas, and all those people who help us, you know, through that harrowing experience. So thank you for participating. We will take your hands for you and give you the photo post.
Perfect. Thank you guys so much.
Thank you.
Right.
Bye,
Thank you
everybody.
so much.
Have a great day. Bye, everybody.
Bye.